Thank you both. And I think if we were attending this meeting live, there would have been a big round of applause for all of our speakers. That was fantastic. Thank you, everybody. We have our speakers here now, and we'll go through some of the questions that we've had. And if there's any other questions, please go ahead and pop them in. One for Dr. Sami is that he mentioned the variants that were looked into from Lebanese studies. Are you considering any other countries to include in the data and looking at it more specifically as you did for the Lebanese variations?
Hi, yeah, so for, can you hear me?
Yes, go ahead. Thanks.
So, so because our update was quite recent, we mainly focused on variant data in just Lebanon. But before that, we actually we reviewed most of the GCC countries like Saudi, Oman. And so we have data from there that we're merging into this new format. And hopefully we plan on updating most of these countries. So.
Fantastic. And I think the important thing to remember is that you've got the email address there. Anyone who's interested in contributing data from their own cohorts are more than welcome to contact CAHGC. And it's a case. Yep. Sorry, go ahead.
I'll put the link to where you can submit your data in the chat box here.
Fantastic. But if you go to the CAHGC website, it's fairly easy to navigate from there. Yeah. So that's great.
Can I ask I think the second question is for
yes,
Dr.
go
Alice.
ahead. For Dr. Alice, yes.
She's asking regarding neuromuscular disease patient with the same gene mutation can show different ranges of symptoms severity. Is there any specific modification variant identified?
Thank you for the question. Alice? Yeah, thank you. Truly, this is correct. The problem is that in different categories of the neuromuscular disorders, you don't have many cases that you can identify this variability in severity. But this is true for the LAMA2 related muscle dystrophy or myrcene deficient muscle dystrophy when we have a cohort of patients. And for those who have the tribal mutation, it is the same mutation, same frame shifted mutation. Truly, there was a difference in severity and disease progression. So to answer your specific questions about the modifier, we have developed a severity score for this group of patients, depending on the highest level of the score who have invasive respiratory interference, like invasive tracheostomy, invasive osteotomy, and for the muscle weakness, they cannot support the head at all, and they are not able to sit unsupported at all. And we developed this severity score, and then we are working on develop a kind of a haplotype that involves 3 categories of genes. Genes that encodes for other laminin protein, not only LAMA2, looking for variations in these genes, and genes that encodes for protein, muscle proteins involved in glycosylation of other protein in the muscle, and genes involved in the cytoskeleton of the muscle, particularly the Z line. So we try to make a kind of haplotype looking for the variation in these specific categories of protein coding genes and see whether we could relate it to the severity score or not. I cannot give you now an answer whether we have found this modified or not, but we are working on this now.
Okay, can I ask one question, Dr. Alice? You mentioned that about the EMG, that not all the doctors are doing the EMG, or that you miss this investigation. Really, in Kuwait, I advise all the pediatric neurologists to send the patient for molecular test, especially with the treatment which is available for SMA. And as a doctor, I found the EMG is a very painful procedure for patients. So we have the molecular test, which is available, which is sponsored by the government. So I think it's before doing any EMG, we do the molecular test here in Kuwait. What do you think about it?
I think EMG was just an example of the deficiency of going behind the standard investigation. Even the creatine kinase, which is a simple test, was not routinely done. for patient to complain with muscle weakness. And for EMG, we have some cases that in spite of muscle weakness and they have convulsions and they will be treated like convulsions. And only when the gene test comes that they are LAMA2 patient, then they sent the patient to do EMG. And it was when it was sent from the beginning, the myogenic profile would be seen. So I know it's painful, but if we, example, if we're doing now the natural history, we wanted to do the registry, we have to have information about this clinical testing. I mean, though painful, but going behind this standard clinical investigation, MRI, it's take a long time, muscle MRI take a long time, and it's very expensive, but it is essential. I mean, gene tests, it's fine, but you have different clinical parameter answered for them or data. I think it will be very important. Even like you said that there is treatment evolving, gene therapy evolving, so you have different biomarker on the clinical level that you can evaluate.
Thank you.
Thank you, Dr. Alice. It's something we can talk about for a long time. It's so fascinating.
Yeah.
I've got a question for Dr. Shakir about the breast cancer work that you're doing. I really enjoyed your presentation. I actually did my PhD in cancer and the Arabic community. So I'm interested to ask you about some of the psychosocial issues and the stigma, particularly where it's a male who has the BRCA gene. Do you find there's a difference when you're counselling families when it's carried by the male parent? And how do you find that?
Yes, so most of my patients are actually female, but you know, the occasional male here and there. You know, I'm sorry to say that, but you know, usually the male patient, they usually run away. They don't want to be tested. Sure. They don't want to be seen. And I tell them, you don't have to do anything. It's just talking. I'm not even gonna touch you without your permission. And then you can decide for yourself if you want to be tested or not. But many of them, they just don't come. Even sure. when you have a patient who is BRCA positive, like a sister in the family. In the future, I would see that the mother, maybe the aunts here and there, and the sisters come, but usually the brothers, they don't, and they're just too scared. They don't even want to hear it. So in this context, I see. I'm sorry, but men are a bit wimpy when it comes to BRCA1 and 2, and they get scared.
Yeah, I think it also is a cultural thing, and it's not only in the Arabic community. I think with the breast cancer susceptibility genes, they're invisible until you get the cancer really. And what I found in my study was where a father was an obligate carrier because his children had breast cancer and then his siblings also. One comment that stuck with me was I was just a statistic until my daughter got breast cancer, then it became real. Do you know what I mean? So it's a very difficult disease because it's not a direct gene, as obviously as you know, there's just so much uncertainty.
So I do have a patient who is he passed away now, but he had breast cancer and he absolutely refused to be counseled. And you know, with the pressure from his oncologist, he told, just go and listen, and you don't have to do anything. No, we're not going to do anything without your permission. And he actually poked his head into my clinic, and he said, "Can I do the test without seeing you?" So I was like, "You need to sign for it. You need to hear. You need to know the implications." It's a long discussion, but he opted not to do it, and he passed away. His daughters did it, and and of course, lo and behold, they do have BRCA2. So it's that kind of fear with men. I don't have an explanation for it. You know, and some men, it has nothing to do with breast cancer, so they do have a prostate or pancreatic. But again, anything hereditary, they tend to, you know, cower from it.
Very resistant. Yeah, that's really unfortunate. We've got a couple of other questions for you. What are the panel genes to be tested in the case where a BRCA gene is triple negative? triple genes are negative for the BRCA gene?
Okay, so triple negative, it's going to be primarily, if you're talking about treatment-wise for triple negative, which means ER negative, PR negative, HER2 negative. This is a pathological diagnosis. So they would say something like invasive ductal carcinoma, triple negative. It means HER2 is negative, estrogen is negative, and progesterone is negative. So in these cases, by far, BRCA1 and 2, if you are considering the treatment options, because there are treatment options other than chemo when it comes to metastatic breast cancer, triple negative metastatic breast cancer. However, if you're talking about a hereditary aspect of the disease, we tend to expand on the tested genes. So we'd like to consider, all other than BRCA1 and 2, we'd like to consider the ATM gene, CDH1, CHEK2, PALB2, PTEN, and TP53. These are essential for doing a panel for hereditary purposes. For treatment purposes, for breast cancer, usually the oncologist is satisfied by BRCA1 and 2.
And most of those genes you mentioned are included in the standard of cancer panels.
Exactly.
Yeah.
Absolutely.
Great. There is a question for Maya, but unfortunately she's had to leave due to the time difference. But the question, I think I can hopefully answer it, is with respect to genetic counselor academic programs in the Middle East, would it be possible to have a joint master's program because resources are so limited in the Middle East? I guess anything's possible if people cooperate and want to work together. I think it would be a fantastic idea, particularly as there's such limited clinics in each of the countries, obviously other than Saudi Arabia, where it's quite more well established. But with clinics, clinics are a big partnership in our genetic counselling programs. They are at least a third of the academic program for genetic counsellors is clinical placements. So I think partnerships between universities and between other neighbouring countries would be a fantastic way of solving that problem of having limited placements within one country. So hopefully that's answered that question. Another question to Shakir is, you're very popular today. In case a patient has a low risk of cancer and they still wanted to get genetic testing, what's the process there? And would the patient have to pay for it?
Right. So in Kuwait, the test is actually free. However, I strongly recommend not to take the test or do anything like that without genetic counseling, with like a proper genetic counseling first. We have actually many cases over the years who actually they just could not accept that testing is not necessary at this point, and they went and they did it in a private lab somewhere, and they ended up with it actually ended up in a disaster. One of them had it actually done, and the results came back with a variant of uncertain significance. The surgeon interpreted wrong and considered it as pathogenic, and she was offered a risk-reducing mastectomy just based on that. And you know what, these cases. So I would strongly recommend that they get proper genetic counseling before doing any genetic testing. And if they are low risk, I'll tell you that during my training in McMaster and Hamilton, it was in 2013, July 2013, when Angelina Jolie went and did the test, and she came back positive, and she went and she did both the risk-reducing mastectomy and the risk-reducing oophorectomy. At that point, the appointments to my clinic stretched out to 8 months in advance, and the vast majority of those patients, they were just scared young women and with no eligibility for testing whatsoever. And one of the patients that I told her, do you have cancer? She said no. Anyone in the family? She said no. I was like, why are you here? And she said, my friend got breast cancer.
Yeah, yeah.
So it's like that. So you get that scare every now and then, and in our job, in the psychological part, we just put them at ease and tell them there is no point in doing the test right now, but with extensive explanation so they can accept it.
Of course. I think that was a worldwide Angelina Jolie effect. We have that the same in Australia.
And it's published, yes.
Yeah, that's right. It's been published.
I have one question for Dr. Sami Bizari. He puts here that we can submit our published data in the CAGS or this site. Can we put any unpublished data if we have unpublished data? Can we put that?
So we have a plan to accept unpublished data, but we were worried about ethics, and maybe we need to have a committee in case there's some sensitive data. But if it's maybe anonymous subjects, yeah. So far, we're just accepting published data.
Yeah.
Only. Yeah.
I think we've got.
Yeah, we have 5 minutes more.
Yes, 5. So it's just mentioning here about Kuwait, does many genetic tests, but nothing's mentioned about genetic counselors. Is anyone aware of any genetic counseling services?
No, really. We do the genetic counseling by our clinician. We have in the center about 14 certified clinician genetic, and they do the genetic counseling by themselves. Still, we don't have any genetic counselor. And maybe because in our society, they don't accept any counseling, only to be a doctor, to certified medical doctor. And that's why our medical doctor are doing the genetic counseling. Although we have some of the PhD holder in genetics, they have a master in genetic counseling, but the patient, they don't accept this. Unfortunately, they don't accept that anyone other than a medical doctor do the genetic counseling. Is it right, Dr. Shakir? Maybe he agree with me. Yeah,
that's true. So they always looking for MD, and they do actually ask about your background, and they ask about your rank even. So they want the most knowledgeable, the one with the most experience to see them, even if it's something simple as like thalassemia or G6PD, but they still look for the most knowledgeable person.
I think that comes back. Sorry, I was just going to. Sorry, go, Dr. Alice.
Yeah, it's just because I may say between my experience in Egypt and in Qatar. In Egypt, it's like in Kuwait, the geneticists who do the genetic counseling. In Qatar, they have also genetic counselor at the genetic unit, but because genetic counselors, they also see some cases chromosomal like Darwin or so on. So their clinic is also crowded, or their duties is overwhelmed by other. So the geneticists themselves also do the genetic counseling for the patient. It's only when it's a complex case with more than one disease, then they refer it to the genetic counseling. But in spite of that, the geneticists themselves also do the counseling for the patient. Yeah.
I was going to say, I think that comes back to how important the Arab Association of Genetic Counsellors is in terms of education and promoting genetic counselling in the region. But I don't think it's only unique to the Middle East. I think genetic counselling is misunderstood by many people, worldwide. It's not one of the best defined professions, and not one of the more well-known professions. So it's events like this, I think, which will, help us communicate more about the different skills that different specialties have. Yeah. So is there any final questions, or we might wrap it up now, because we have a poster session now, and anybody can access the posters through their Huvo app under additional resources. Join me, everybody, in virtually thanking our fantastic speakers. This has been a really fascinating session. I can't believe 2 hours just went by. It just flew by. It was so interesting. Thank you, everyone. And thank you to my co-moderator, Dr. Layla. It's lovely to meet you all. And inshallah, we'll all meet face to face one day.
Inshallah. Thank you, Dr.
Inshallah.
Muna. Really, inshallah, we will meet
Best everybody
face-to-face.
for the rest of the conference. Bye-bye.
So much.
Thank you.
Bye.
Thank you, everyone.
Bye.
Thank you.
Thank you.
Bye-bye.
Thank you, everybody.